Okay, we'll get started and hopefully some more folks will join us in the first couple minutes. Hey, hi everyone. Thank you so much for joining us today. My name is Haley. My pronouns are she and her. I'm a project officer for CPHA's Substance Use Project, and I'll be co-moderating the webinar today along with my colleague Karen. While we're working remotely, I'd like to acknowledge that CPHA's office is located on the original unceded territory of the Algonquin Anishinaabe people. They have been the guardians of this land for millennia, and CPHA is grateful for the example their stewardship provides. CPHA is committed to working with First Nations, Inuit, and Métis peoples and their governments in realizing meaningful truth and reconciliation. And now I'd just like to go over a bit of housekeeping. All participants are muted, but we hope to engage you throughout the webinar through other features. If you have general comments, please post them in the chat box in the toolbar at the bottom of your screen, visible to all participants. If you have questions for the presenters, please post them in the Q&A box. The format for this webinar will involve a presentation followed by a question and answer session at the end of the webinar. If you think of any questions during the presentation, please drop them in the Q&A box and we'll try to get to them all in the last several minutes if possible. This webinar is being recorded and the recording will be made available on CPHA's YouTube channel in the coming weeks. Once again, thank you for joining us today for this webinar entitled Involuntary Stabilization Care of Youth Who Overdose, More Harm Than Good, which is being co-hosted by the Canadian Public Health Association and the Harm Reduction Nurses Association. As is the case across Canada, the province of British Columbia is in the midst of an overdose crisis that is having devastating impacts on youth and others who use drugs. Drawing on a published commentary with the Canadian Journal of Public Health, Advocacy Efforts, Clinical Practice, and Lived Experience, this presentation will provide an overview of BC's recent proposal to amend the Mental Health Act and sanction involuntary hospital-based stabilization care of youth who overdose. In the first part of the presentation, the presenters will discuss three key areas for public health deliberation related to these proposed legislative changes, including 1, the evidence underpinning involuntary care, 2, ethical considerations, and 3, the potential for unintended and unevenly distributed consequences. In the second part, the presenters will review advocacy efforts related to this issue and explore what this turn to mental health law means for youth who use drugs and other stakeholders in BC, and potentially nationally. And now I will introduce our three presenters. So Mary Lou Gagnon, whose pronouns are she and her, is an associate professor at the School of Nursing, Faculty of Human and Social Development at the University of Victoria, and a scientist at the Canadian Institute for Substance Use Research. Her work focuses on harm reduction, nursing practice, and social justice. She is the co-founder and current president of the Harm Reduction Nurses Association. Callie Sedgmore, whose pronouns are they and them, is a PHS peer supervisor at Molson OPS and Mobile OP Unit, youth peer support, VCH peer harm reduction leader and outreach worker, and has been a harm reductionist with a focus on youth harm reduction and stimulants for 9 years. Currently, they are sitting president of the Coalition of Peers Dismantling the Drug War. They're Indigenous and love meth. Trevor Goodyear, whose pronouns are he and him, is a registered nurse, PhD student in the School of Nursing at the University of British Columbia, and addiction medicine research fellow with the BC Centre on Substance Use. Trevor has clinical expertise in youth mental health care, and his current work focuses on equity-oriented research with queer and trans youth who use drugs. Welcome to our presenters, and thank you so much for joining us today.
Great, thank you, Haley, for that intro. Again, my name's Trevor, pronouns are he, him. Today we're going to be talking about involuntary care of youth who overdose. And as Haley mentioned, we're really going to be interrogating the evidence, ethics, and potential harms that come with this policy. I'm going to kind of get us started with the next few slides, but before I do that, Mary Lou, just want to say hi, and Callie, just say hi so folks can recognize your voices.
Hey. Hi. Salut, bonjour. Bonjour, francophone.
Thank you, merci. And Haley, thank you as well for the land acknowledgement. I'd also like to acknowledge that Callie, Mary Lou, and I are calling in from unceded territories of the Musqueam, Squamish, Tsleil-Waututh, and Lekwungen peoples. And with this, I'm a nurse, Mary Lou's a nurse. Today we're talking about healthcare and about nursing a little bit. And I think it's important to acknowledge that nursing has been complicit in historic and ongoing colonial harms with Indigenous peoples. So whether that's through Indian hospitals or forced sterilizations or the systemic racism that continues today. And we certainly have a lot of work to do in terms of acknowledging and redressing those harms. And spoiler alert is that involuntary care does not fit with that work. I'd also like just to position ourselves in this research. So we're coming at this from many different perspectives. So from our clinical nursing experiences, our work in peer harm reduction and outreach, our research work, especially with folks who use drugs, and our advocacy and our activism with communities of people who use drugs, both in BC and also more broadly. And I think you'll notice throughout this presentation that we're coming at this with many different perspectives. There's going to be a shared thread. So we're really primarily invested in equity and social justice when it comes to the health and well-being of people who use drugs. And Callie and Mary Lou, anything to add here about what brought you or what brought us to this talk?
No, I'll keep that for the talk. I think let's just go right in it. Unless Callie, you want to add something?
No, I think we should just jump right into it.
Do it. So yeah, I'm going to be controlling the slides for this presentation, but it really is going to be more of a back and forth between Callie, Mary Lou, and I. So both of you feel free to butt in whenever. I won't be offended. And in terms of the outline, Mary Lou is going to start us off with a brief history of drug policy approaches. And then I'll really narrow in on this specific policy and about the evidence and some of the ethical issues. And then we'll turn to, if not involuntary care, how else can we support youth and what can we do better? And we should have about 15 minutes for questions at the end. And I'll just note that we're talking about some pretty heavy topics today. So overdose, coercive care, stigma, etc. So if folks need to step away for a couple minutes or log off and hopefully come back, do what you need to do to take care of yourselves. That's totally okay. And Mary Lou, you were going to start us off with a brief overview of drug policy approaches.
Yeah, and I mean, considering you don't have a lot of time to go over the history, I think the title was inspired by this book, and many others have used this idea of more harm than good. And I think that summarizes the history of drug policy. And we have to situate what we're talking about today within like a very long-standing history of opting for the most intrusive and coercive and restrictive approaches to substance use, as opposed to more voluntary harm reduction, kind of peer-led and collaborative approaches. So the topic we're talking about today is just, really fits in a very long history of more harm than good, and policies that are absolutely not informed by the experiences and the voices and the expertise of people most affected. We can change that, but involuntary care for youth is absolutely not the right way to go if this is what we're committed to. And the public health emergency that we're in is disastrous and totally preventable. But we have to look at it as an opportunity to address the drivers of harms and invest in harm reduction. It is not an invitation for more restrictive and oppressive measures. And a case study of that is what we're talking about today. So I think it's important to locate that within a very long history of doing more harm than good, and that we have an opportunity here to stop the harms and to actually correct our way of approaching substance use. So I think this just sets us off on a note of more of a historical perspective. And this is not a new issue, but it's one that we can address differently.
Great, thank you, Mary Lou, and thanks, Alex, for sharing that poll in the chat. In this presentation, in addition to drawing on our clinical and work experiences and lived experiences, it's also drawing on a recent commentary that we wrote about involuntary care. So this is going to kind of come out throughout the presentation, but definitely feel free to look at this commentary if you want more detail, or if you want to look at more references on the topic, because there's a bunch of additional nuance and context in that commentary. And yeah, this brings us to the current issue, so involuntary care. Briefly, this is a policy that was introduced in BC in the last year that suggested proposed amendments to the Mental Health Act that would allow clinicians to involuntarily hold youth following an overdose. So initially for a period of 48 hours, but up to 7 days. And like I said, this would be through amendments to the Mental Health Act, so kind of changes to an existing policy. And in terms of a background of where this policy came from, as I'm sure most of us are aware, or all of us, BC is in the midst of an overdose crisis, and Canada is in the midst of an overdose crisis. But BC has been particularly hard hit. And as this graph shows, the number of overdose deaths has really skyrocketed since about 2012. And I want to stress, as Mary Lou already mentioned, this crisis is directly linked to a highly contaminated and poisoned drug supply. So a drug supply where fentanyl and related drugs are able to cause overdoses in very tiny and in some cases undetectable doses. So, for folks who are using drugs, this is a drug supply that's very unpredictable and very dangerous. And we'll talk about this later, but there are some structural interventions we can do to address this drug supply beyond involuntary care. So the overdose crisis is affecting everyone. Many of us know folks who have experienced an overdose or who have been lost to an overdose. And an official public health crisis was declared in BC back in 2016, but certainly it's been an issue for years longer than that. And there was an escalated response to this public health crisis in 2018, which again, I would argue is good, but is a bit too late. And since 2016 alone, so since this public health crisis was declared, 85 youth have been lost to overdose. And thinking beyond youth, more than 6,000 people have died in BC alone. And this is from like late 2020 data, so we know that many more have died since then as well, unfortunately. And 2020 has been the worst year of the overdose crisis to date, so certainly more work to be done and urgent work to be done. Callie or Mary Lou, anything to add here before I jump into involuntary care?
I think just like impact of how much youth are suffering in this overdose crisis to not having access to harm reduction supplies or just not getting their needs met due to the fact of being a youth. So it's difficult for youth to deal with this crisis, but on top of that, they're dealing with a lot of stigma and shame to it too.
And I think that's a really important point, because I think going into the conversation that we're about to have, it's important to point out that youth don't have access to the same standard of harm reduction and substance use care as adults. So they're already at a huge deficit. And so to offer, and this is why we wanted to talk about this today, to offer them this as a solution when they're in fact really not being provided the same level of care is really not the proper way of addressing the issue.
Yeah, great point. And I mean, the previous slides also are just focused on the number of folks who have died, which is of course hugely important, but health and social impacts extend way beyond that when it comes to the overdose crisis and the system of care for people who use drugs. So thank you. Yeah, so within the context of the overdose crisis and youth experiencing overdoses and dying of overdose, the BC provincial government and many advocates have called for increased policy responses to this crisis, and rightfully so. But one of these policy changes is involuntary care. So those amendments to the Mental Health Act that would allow us to keep youth in hospital against their will. And this is a bit vague because we haven't had much publicly available data about what stabilization care or what involuntary care would actually look like. So whether it's just the hold in hospital itself or all of the interventions that might be offered while in hospital. And again, very little detail about what those interventions might be, but based on my clinical experiences and the research I do, I know that this can be very broad. So it could be both consensual and non-consensual interventions like access to counseling, opioid agonist therapy, other harm reduction services, and also getting more restrictive too. So thinking about like chemical restraints, physical restraints, being in a locked hospital unit, and so much more. So that it's quite broad what this policy could entail, but we haven't gotten as many details as we need.
And Trevor, I don't know if it's a good time to mention that, across Canada, mental health legislation looks quite different, and why we became very interested in this and alarmed by this proposition is that in the context of BC has it has been said many times, the worst mental health law in the country, where actually people don't have a right to refuse treatment once they're involuntarily detained. So I think this conversation needs to be located within a province where the mental health law is particularly harmful.
Yeah, and not only that, but also, the impact of the overdose crisis here too is that this policy would likely be used at greater rates than that in other provinces. And when we're thinking about involuntary care, or also named secure care in other provinces, the evidence to support these interventions hasn't been very conclusive. So we don't really know if involuntary care used elsewhere is effective at keeping youth safe and healthy over the long term. So a common example that folks use when pitching and evaluating involuntary care in BC is comparing it to other provinces like in Alberta, but their models are very different as well. So the effectiveness of involuntary care with youth has not been specifically evaluated. So there's, like I said, there's real ongoing debate about whether this intervention actually works or whether it works well. And available data to support this intervention is really limited to internal monitoring surveys and program evaluation type resources, which can certainly be good, but can also be very biased and may lack scientific rigor. So they're not subjected to peer review, for example. So we need to interpret these data with caution. And these three papers that I have on this slide go into a ton of detail, like for and against the evidence on involuntary care. So I definitely encourage folks to look at those if you want more. But we do know, however, that there's a large body of evidence showing that coercive healthcare treatments, especially with youth, but also with adults, are ineffective. So they're ineffective at keeping folks engaged in care, preventing overdoses in the future, and just keeping people healthy and safe. So altogether, this raises serious doubts about the appropriateness of involuntary care in BC. So taking a step back, does involuntary care work? Right now at this point, all we can really say is that the evidence is mixed, it's biased, and it's quite inconclusive. And this lack of evidence needs to be matched up against the ethical concerns that come with involuntary care, because we can't just look at evidence by itself. We also need to think about the impacts and the harms that policies can have on people. Anything to add, Callie or Mary Lou, before we jump into more ethics?
That and just the evidence is very mixed too, because it's a lot of people don't come forward when they've been involuntarily cared. In involuntary care, because it's a very kind of shameful thing, but also just a very embarrassing thing. Not embarrassing, but just something that happens that's really can be really tragic to people and really traumatizing. So a lot of people don't talk about it because of the of being traumatized by it.
Great point, Callie. And we've talked about this before, but involuntary care exists outside of this Bill 22, right? So even outside of the bill, we know that folks are being hospitalized and treated against their will or in a coercive way in many settings. So very traumatic, like you said. So like I said, we need to be thinking about evidence in the context of ethics. And public health ethics frameworks tell us that the more intrusive or coercive an intervention is, the more it necessitates substantiation. So the more evidence is needed to prove it or to justify it. And in this context, we have a highly intrusive intervention with very limited or poor evidentiary support. So very big red flag. And in light of concerns such as these, a number of community organizations and individual researchers, clinicians, and advocates, including ourselves, have spoken out against involuntary care. And Callie and Mary Lou, I know you've both been quite outspoken on this policy. Did you want to, maybe speak to the lay of the land in terms of these advocacy efforts and where we are today?
Callie, do you want to start?
So it started with just finding out about the bill through Twitter. Actually, it was really weird, but finding it through Twitter, and then someone started, and then I realized what it was, because they tried to ask for this Secure Care Act bill before in 2018, and so we them bringing it back and trying to be like, this will be but trying to name it under something else was just not okay, but also just because of knowing from experience, but also just from friends' experiences with involuntary treatment, is just that never works. So being able to fight through that, but we did a few we called press conferences over Zoom, and then just pulled up some evidence from BCSU, and a few other people had things to say, like especially the coroner. I can't remember what she is now, but she's the coroner of BC, and she's having her speak out about it too was really nice.
Yeah, thank you. And Mary Lou, anything to add there? I also have some thoughts, but.
Yeah, like that's, I'm glad that you brought up the immediate response of the coroner, who right away flagged the risk of especially increased mortality associated with this bill, because, you know, the moment that you detain someone and their tolerance decreases, like the moment that they would get out of the hospital, you've just exposed them to a more lethal, for sure, experience, potentially deadly. So in terms of benchmark for safety, like that argument of detaining youth does not hold on any level. And as nurses, we got involved from the Harm Reduction Nurses Association, mainly because of the harms associated with this bill, and our primary mission being harm reduction, right? And also because we work with a lot of times adults who've experienced so much harms at the hands of a healthcare system, and also the correctional system and child protective systems. And when we work with adults, we see how difficult it is to repair a broken relationship, especially in the context of a care relationship. And that harm, if we can prevent harming youth, it also means a lifetime of potential engagement in care and trust. And that trust, once it's broken, is very, very hard to rebuild, with good reasons, right? And then we also were very impressed with the position statement that the BC Nurses Association released with respect to involuntary care, and the fact that they highlight that, you know, nurses don't make the decision to detain someone under the Mental Health Act, but nurses are at the forefront of doing the bulk of the work between the person who decided to detain someone and then the patient. And that puts nurses in a very tricky position ethically, and it can create a lot of moral distress. And we've heard from some of our colleagues within the harm reduction community that some of them have had to change positions because of the heightened moral distress caused by these kinds of approaches that we know don't work. So as nurses, it's a position that's impossible to hold, right? To be kind of in the middle. So we felt we were had a responsibility to intervene and voice our opposition.
Well said, and really just so many different levels and key voices coming at this from many different angles, but all kind of speaking out and saying this policy isn't the answer. And I've listed a bunch of organizations on this slide. I should have said too that all of these folks have spoken out against involuntary care, but there's many, many more in addition to the ones listed here. I did want to add too that thankfully the advocacy around involuntary care in BC has worked to a degree. So the provincial government has listened for the moment and put the bill aside, so it's not going to be tabled this spring. But that doesn't mean our advocacy should stop, because involuntary care, like I said, still exists in different forms. We have policies for it in different provinces. And who knows, maybe this policy will come back in BC, whether in its current format or in a different version.
Yeah, and the report that you have up there, I would really recommend if folks on the webinar haven't seen this report. It's a very, very comprehensive report that was just released in January this year by the representative for children and youth. And it's very, very detailed and really speaks to the harms that we're mentioning in this webinar, and also shares a lot of the lived experience of youth and what it feels like to be detained. For the main part really is that being detained in often adult facilities on inpatient psychiatric lock units. And once you've read the testimonials, I really would say, please do that first. It's very important to hear those voices and those experiences. So I really encourage everyone to read that report.
It's very new too, so very real and current. I think it just came out last month, so very fresh. So we've spoken a bit about some of these concerns and the harms. We're going to expand on these by drawing on some key ethical principles. So the first principle is that of beneficence, or do good. So earlier we were talking about evidence, and we don't have the evidence to confidently say that involuntary care works or that it works well. And as Mary Lou was saying earlier, like, we need to be thinking about not just in hospital, but what happens after hospital. So we got to think about, if we're lowering folks' like opioid tolerance, they're at a higher risk for overdose after they leave hospital. And here I want to acknowledge that, you know, many of the goals underpinning involuntary care are more leaning towards like abstinence. And this might contradict youth's own goals. So many youth might be more invested in harm reduction at present, and you know, stopping using substances might not be in their vision at present or ever. So it can totally contradict youth's own needs and visions. Callie, Mary Lou, anything to add there?
Well, and just drug use in general for youth, it's like a lot of times it can be something they're doing to stay alive, or just something they're using to cope with whatever's going on in their life, especially for youth in care and Indigenous youth. It's a very difficult thing. But yeah, like and also with this Involuntary Care Act, they wouldn't even phone a parent or guardian right away. They can phone any trusted adult, which is really not okay too.
Yeah, and I mean, that brings us to some of the additional harms. So we've talked about overdose being the big one here, but yeah, like you said, like some youth may not have as many supports or loved ones with them, and might not have that sort of like advocacy and circle of support. So it can totally disproportionately impact certain youth. And Callie, I know in our last phone call last week, we talked quite a bit about some of these potential harms. Did you want to expand on some? I've got them here.
Yes, we all know the risk of overdose, but like trauma, and trauma and distrust of the medical system, they would not, like, for instance, if a friend overdosed, they probably would not call 911. It's more likely they won't, because they're scared of like being detained and stuff like that. So they would just usually leave their friend. And just having no trust with the healthcare system at all. So they wouldn't see doctors as often. And for a lot of youth too, it's just, it's just that they wouldn't access healthcare as much as they should. And then that creates a lot of harm too, because it's also them not seeing any doctor. And if they hurt themselves or something like that, they wouldn't go into a doctor or a hospital to go get help. They would rather just ride it out usually. And that's really, especially when you're growing, it's really difficult. And just there'd be a lot of fear based around it. And then just stability, because like if you're locked up for 7 days, you come out and let's say you're homeless, or you were in the sex trade or something like that, and you come out and they're like, where are you, come from a really violent family, they're going to ask you where you've been for 7 days, and you can't really give them an answer if they don't know where you were. And that's also really harmful too.
Thank you for that. And you know, just thinking about the severity of some of these harms and the severity of the overdose crisis, I think we really need to do, like, just take a step back and reevaluate the bigger picture here. So it's not just as simple as keeping youth safe while they're in the hospital.
Mm-hmm.
And then we've already touched on this, but just to recap, is involuntary care really undermines youth autonomy and capacity to consent. And Mary Lee, you talked earlier about the Mental Health Act and already have some restrictions in terms of consent there. And this just takes it a step further. So it's a more severe and blatant violation of capacity. And involuntary care contradicts the ways that many clinicians are taught to approach youth and engage with youth. So, you know, we're taught to engage with folks in a way that's strengths-based and trauma and violence informed, resiliency oriented, and so on. And involuntary care really doesn't match up with that, and it's more restrictive. So lots of drawbacks.
Yeah, and I think part of the critiques and the response to this bill is that it could very well launch a charter challenge, like because of, you know, violating youth rights. So I think, you know, we're not there yet, and hopefully this bill and, you know, this kind of approach does not really make a comeback or become the go-to. But, you know, I think we're talking about really like a situation where it would raise some significant questions about the infringement on the rights of youth. And so that's to keep in mind, because it's that to that level, right?
Thanks. And I saw some discussion in the chat about social justice and the In Plain Sight report. So Our next piece is around justice or social justice. And it's important to consider that involuntary care would unfairly or inequitably impact key subgroups of youth. So like structurally vulnerable groups of youth. So this could be like queer and trans youth, youth who've been in care, BIPOC youth, etc. And these are youth who face different and often intersecting forms of oppression and marginalization in society. So whether that's homophobia, transphobia, racism, and the list goes on. And I want to preface this by saying that healthcare workers certainly do a lot of good, and I think COVID has highlighted that in the last year. But at the same time, we do know that stigma is quite pervasive within our healthcare system, and clinicians, including nurses, can be stigmatizing.
Well, especially when it comes to drug use too, if you have a drug problem, they look at that first before they look at your health problem, and that's really frustrating.
Yeah. Totally. So youth in involuntary care right off the bat likely to face substance use stigma, denial of access to harm reduction in certain hospital settings. And then for other youth and other youth may face different forms of stigma and discrimination on top of that stigma. So again, racism from healthcare providers, queerphobia, misgendering, etc. And I have two reports on this slide. One's about, Indigenous specific racism in BC, and one's about intersecting forms of stigma in healthcare across Canada. So tons of detail here about, what healthcare workers and the system can do better in terms of addressing stigma and structural racism. And yeah, I can also just add too, like we need to be thinking about, especially in plain sight, the report on the right. So we know that, BC and Canada more generally, it's a very colonial context. And Indigenous peoples, including youth, are already overrepresented and institutionalized at greater rates and unfair rates compared to non-Indigenous folks. So you can just look at the child welfare system or the criminal justice system for two prominent examples. And we need to think about how policies like this might further add to that institutionalization and further contribute to these inequities and these structural violence that folks are facing. Callie, I know you had lots to say about this last week. Did you have anything to add?
Well, it's just like going back for a lot of Indigenous youth too. It's like if you're detaining a youth, you're taking them away from their families and stuff like that. So it's bringing back the practices of what residential schools did, take away kids from their homes and stuff. And that's really not the best practice. And also whatever happened to not detaining youth in jail and stuff like that. Now this is kind of the same thing because they use the word detain. So that's still locking kids up. And that's not appropriate either.
Yeah, and those enforcement-oriented approaches can take many different shapes and sizes, and this is one of them for sure.
Yeah, and I would add that, considering that in that report that I mentioned before, like we have data, I mean, not that much data, but enough to know that it's involuntary detaining youth has actually gone up by 162% over 10 years. So it has become in BC, and I would probably argue that in the rest of Canada, we're seeing a similar trend, that it's kind of the go-to because of failures of the system to offer voluntary options, to actually meet people where they're at, to offer really good mental health services. So instead of investing in all these systems and providing good care, we're actually resorting to detaining youth more and more and more. And it has become kind of like the go-to practice. And it's extremely problematic. So I think we have to situate all this within failures of systems to provide good care. And instead of fixing that, we're kind of like removing people's rights, and especially youth rights, and especially these subgroups that are already so disproportionately impacted and furthering the trauma. So when you put all that together, it makes it for a very difficult position to hold ethically.
Thank you. And yeah, taking a step back, just kind of broadly for this policy, I just wanted to kind of come to our final verdicts about this policy. So, advocates of involuntary care do have good intentions. I do believe that, but we need to be coming together and responding to the overdose crisis in a way that's ethical, evidence-based, and respectful of youth autonomy and rights. Unfortunately, the evidence underpinning involuntary care is poor to mixed. There are a number of ethical concerns, and we've just named a few of them today. And there's a real need to step back and reevaluate our options and think differently about what we can do better or instead. And to do this, so if we're not going to move forward with involuntary care, how else can we keep youth safe from overdose? To answer this, we need to start asking youth what they need and really engaging them in policy decisions. So Callie, for example, you mentioned hearing about this policy over Twitter. That's totally unacceptable, right? Like,
it's something Judy Darcy should have announced more formally instead of just putting on Twitter.
Mm-hmm.
And then also just how we learned about the pause of the bill too was through Twitter, which was not. And then also just about meaningful policy engagement too. It's about having youth at the table that's at the table too. And just like for whatever it's going to affect them, there should be youth at the table too. And it's really not a tokenizing way, more just like let them have their voice be heard and stuff. So.
Sure. And, you know, when we're thinking about bringing youth to the table, there's often advocacy for bringing other stakeholders. So whether that's like parents, families, clinicians, policymakers, so on. And I'm all for that. But certainly youth need to be centered in these talks and really brought to the forefront.
And from different walks of life too, for a lot of youth too, like ones that have experienced it from homelessness or that have experienced it from living from in youth and care and stuff like that. So.
And yeah, I also want to stress that youth are already doing amazing advocacy work about drug policy and so many other issues affecting the health of youth. And Callie, did you want to just take a sec and talk about your Crackdown podcast or tell folks where to access it?
You can access it on Crackdown. I can't remember the website, but yeah, you're able to. It's just I'm talking a little bit there just about how involuntary care would not work and just like how it's just the disadvantages of it, and yeah, and talk a bit about that, but also just my experience and other things.
Thank you. And yeah, just to echo again, those knowledgeable youth and those voices are out there. We just need to be asking the right questions and taking the right steps to engage folks.
Yeah, and to that point, I think like the standard.
So what other options?
Oh, sorry. Can you hear me? Okay. Yeah, I was just going to say to that point, the standards should be the same across the board. So if you're undergoing cancer care because you have breast cancer and government makes a decision without engaging you, and they're suddenly, for example, going to say that they're going to force you to do something or remove something that you would normally have access to, and they don't consult any of the groups that are going to be the most effective, the people undergoing cancer care, right? So it's like sometimes I feel because people use drugs or because they're young, like suddenly that benchmark does not get to be applied. Like suddenly it's like, oh, well, because you've used drugs or you're younger, like we're going to assume that you should not have a say and someone else is going to decide for you. And I think for me, it just cuts back to using the same benchmark. It should be no different. There's absolutely no reason to operate differently. And so I think we just have to sometimes just get out of our situation and maybe apply it to something else and then apply it to ourselves to realize that we would never tolerate this level of kind of overriding or paternalism to apply to us, right? And so nothing like putting yourself in someone's shoes.
Well, that and just like about how we, like when it comes to youth, a lot of times we approach it to this we got to save them method, and that could be actually more harmful than good. Like you shouldn't be saving them, you should be listening to them and just hearing what they got to say before you make decisions for them.
Totally. And I have a picture a couple slides ahead about how involuntary care is often pitched as like a safety net. You know, I wish that were true, but sometimes these safety nets are actually harmful drug policies. So we do need to reevaluate. And then in thinking about reevaluating, like I can speak from my research and my clinical experiences about like what youth have wanted instead of involuntary care. But Callie, I know you do a ton of work, and I was wondering if you could speak to this.
Yeah, so like when we talk about youth specific harm reduction services, we're talking about like places where it's not youth friendly, but more where youth are able to access it, like an OPS site that's run that's more use friendly instead of just them going to an adult one that's kind of intimidating. And voluntary substance use treatments, it's just about like when they want to get better or they feel like they need treatment or detox, it should be them making that decision, not anybody else. Youth have a hard time accessing safe supply is a big one, and just better policies around youth that use drugs, because there isn't many, and there isn't, a lot of people don't like to talk about it because they don't want to accept the fact that youth use drugs, but it's a fact that a lot of people need to understand.
And I'll just add with that, like, voluntary substance use treatment piece, like, you know, when we're thinking about BC, there's not great capacity for voluntary substance use treatment. And there's a lot of work underway to increase that. So increases in like foundry institutions across the province. Institutions is the wrong word there, but there's a lot of good work being done. So we need to be focusing on that rather than these involuntary substance use treatments.
Yeah, and I'm just going to drop a link in the chat as well of the recent report, recent 2018 of that representative for children and youth around the youth voices for substance use and some very specific recommendations. Because I know when we talk about this, the question is always, well, what do we do? And there are actually so many things we could be doing. And so if you want to just take a peek at that report for those of you who really want concrete recommendations, there's some pretty good ones in there.
Yeah, and for those that don't understand what I mean by youth-specific harm reduction services, it's more just like when a youth goes into a harm reduction place, like a needle exchange or anything like that, they get looked at differently. They usually get questions and just being like, oh, you're too young to be in here, but here's some needles, and the youth will never return to that place usually. So when I ask for youth-specific harm reduction services, it's a place where youth can feel comfortable and feel like having younger peers there and stuff like that would make it more accessible for them, and somewhere where they can actually like maybe chat with someone that's kind of around their same age range or has experience with drug use. And I don't know, but yeah, that's about it.
Great, thank you, Callie. And, you know, I want to kind of rush through these next couple slides. We don't have much left, just so we have some time for questions. But Mary Lou, you talked earlier about, you know, nurses or clinicians being stuck in the middle at times and those experiences of moral distress. Did you have anything to add here?
No, because I think I covered it earlier, but this is the reason also we wanted to get involved. It's just important, and we're hearing from colleagues that it's been increasingly difficult to work both dealing with the overdose crisis that is taking such a toll, but also seeing that the solutions being proposed are not the right ones. Like that creates a very, very difficult situation and can lead to distress, and us as a community losing some really excellent clinicians as well.
Thanks. So in terms of next steps, I'll breeze through this, but really, like I said, bringing youth to those policy tables and talking about what youth need and what youth want. And really starting to think about these equity-oriented structural interventions. So access to a safe and accessible drug supply, and starting to unpack some of the barriers that prevent people from accessing substance use services, like criminalization and poverty and stigma and so on. And we've already talked about this a bit, but I just want to say that involuntary care exists regardless of this bill. So there's a real need to critically interrogate the state of involuntary care in Canada and in BC. So, you know, we've long been calling for a reform and reevaluation of the Mental Health Act. And again, this is just super, super important and long overdue, I'll say. And then in conclusion, so I'll just stress that advocates of secure care or involuntary care have good intentions. Unfortunately, these good intentions can sometimes cause harm. And when we're approaching these public health issues, we need to really be ensuring that our interventions are informed by ethics, evidence, and the values and needs of the folks who we're trying to serve. So we need to reframe and critically. I have our references here in case folks want to do more reading. I also want to take a second to acknowledge and remember all youth and people lost to overdose and impacted by overdose. And acknowledging also all the folks who have done and are doing important work in this area. So there is amazing work being done by youth, clinicians, public health professionals, so much more. So please continue doing the work. And then thank you to the folks listed here for their help in informing the ideas for this presentation and helping to write the commentary that we had up earlier. And I think that's about all we have. And we have 10, 15 minutes for questions. And Callie, I know you said you might have to duck out a couple minutes early, but that's
Yeah.
Okay. And thank you, everyone.
Thank you so much, Trevor, Mary Lou, and Callie, for your really informative and impactful presentation. So we'll spend the rest of the time answering questions. Please feel free to drop your questions in the Q&A box, but we do already have some that have come in, so I will start listing those. So someone asked, what would you tell a parent who is wanting to help their child from what they view as a dangerous, potentially life-threatening situation, and how might you persuade them to take a more harm reduction approach?
Callie, I feel like this is right up your alley. Did you want to?
It is, and it's a really tough one because I'm not used to dealing with people that have parents. That's my thing. I'm so used to not like I talk to parents sometimes, but it's very rare for me to have youth that have parents. So I guess one way, if they're going to be harmful to themselves, it's just like better off just trying to calm them down as best as you can. But if you can't, then just trying to get professional help with that. And just like by detaining them through that would actually be more harmful because you're creating a trauma that they don't need. And that trauma can be really impactful for a long time and also can make you lose your relationship with your kid too. So by bringing a harm reduction approach, it's just by just trying to reduce harm by just trying to chat with them or like talk with them calmly and just like other things like that. I can't think of anything else because I'm not used to dealing with parents.
That's great.
Yeah, and maybe what I would add is that parents have actually have such a strong voice and access to policymakers and decision makers. And they can use that very strong voice to advocate for the broadest range possible of voluntary services. And I would say we could really use their strong advocacy for really providing the best kind of tailored services that we can to as many youth as we can outside urban centers as well, right? Sometimes we have a very urban centric approach too, but like across the province, across the country, like we could really use that voice to push for that first and foremost. I think politicians, when given a quick fix, can often default to proposing a bill like that and then failing to address the bigger problems, which is the lack of access to voluntary services. And at the end, parents will not be in a better position because aside from, let's say, a 7-day detention and these approaches that, yes, create more trauma and issues and likely more substance use in the long term, there will be nothing else after that, right? So I would say just be careful to not resort to this as being the fix or the solution, to really put pressure on governments to provide the best care possible, because youth deserve the best care as youth who suffer from all sorts of other health issues.
And with that discussion around pressure and voice, I think it's important to also find common ground with parents or with any, people involved in youth's lives. So folks who are proponents of involuntary care or harm reduction, might be both. We all share the same vision of wanting to keep youth safe and healthy and alive, right? So I think we can just right off the bat acknowledge that and then try to come together and find solutions. And also just acknowledging and validating people's anxiety and their concern, right? Like someone experiencing an overdose, your child experiencing an overdose, it's a very stressful event. So just taking a step back and first and foremost, just acknowledging that and validating the person's experiences, and then coming together to find equitable solutions, like Mary Lou said.
Thank you so much for your responses. So the next question we have would be, beyond what you've already mentioned, are there any effective options to promote consent-based care and harm reduction that meets the needs of youth that you'd like to draw particular attention to?
I can speak. Go ahead, Kelly.
Oh no, I'm good.
Okay. I was going to say earlier, one of the things is Foundry has been scaling up their sites across the province, and they've been a great resource for like harm reduction and voluntary substance use services. And, you know, I'm speaking more to the Vancouver and the BC context, but certainly community health centers are great resources, peer-based services and like youth-specific services, with which Callie touched on earlier. But really just services that are low barrier and that are accessible and safe for youth, right? And services that people are going to want to come back to.
Yeah, and we know that with adults, there's enough literature on this showing that the harm reduction is often like the main path to accessing more healthcare. And so if you don't have like that full range of harm reduction services that we would offer to adults in BC for youth, we're missing probably the main entry point into a broader kind of access to care approach. And so to not forget that, you know, we know a lot from adults that this is often how people access treatment, is by first connecting with harm reduction, because it just makes a lot of sense.
Definitely. Thank you so much. And maybe I'll move on to the next question. So there was a situation where there was a court order to call police on a client at a safe consumption site. How can we try and repair that relationship with that youth if they decide to access the site again?
I can speak to this. To repair that relationship is going to take a while. Like I've lost trust with a lot of, lost trust, but also just like have had situations like that, but never had to call the police on the youth. But just the best thing you can really do is just like give them a space for a bit, and then just quietly like starting small talk again, but just don't jump at it and don't try apologize for it unless they ask for that, because it's if you try to apologize for it, they might just be like, why they'll go again with why they were detained and stuff like that. It's really frustrating for a lot of youth. So just like letting them lead the conversation, let them lead where they want to talk about.
Yeah, and I'll just add that it kind of like ties into those broader issues too, right? Like people who use drugs and youth who use drugs have so many issues with police, and it's not because of criminalization and you know the past of police and their relationships with youth, especially if we're thinking about like queer and trans youth or BIPOC youth, etc. So you know there's a real reason and a valid reason why folks might be scared of police and scared of enforcement-oriented approaches and punitive approaches. So I think we need to start addressing those broader issues as well.
Definitely, yeah, and thank you very much for your responses to that question. So if there are no other questions in the chat, I think we will wrap up. Thank you so much to our presenters for joining us today and your wonderful presentation. Thank you to everyone who's attended the webinar. And I'd like to acknowledge that what folks are saying in the chat about parent and family voices, and we'll definitely take note of that for our future work. Yes, thank you very much for joining us today. Please stay tuned for future webinars in our CPHA substance use series. And if you have any questions at all, please feel free